Discover KDH Collective's Leaning into Therapy podcast, an enlightening exploration of therapeutic approaches and evidence-based protocols. Join us as we delve into the vast landscape of therapeutic interventions, guided by the belief that collective intelligence surpasses individual expertise. Led by KD Holmes, a licensed professional counselor with 16 years in private practice. This series offers valuable insights, expertise, and training from a team of skilled therapists. Prepare to immerse yourself in the world of therapy, created exclusively for therapists by therapists. Welcome to KDH Collective's Leaning into Therapy. In this podcast, Ashley Rush, PLPC, is going to be interviewing me about a class that's coming up. I'm KD Holmes. I'm doing a class on OCD, and I wanted Ashley to interview me because she knows so much about OCD. She's always taking training. She's always learning about it. Anxiety disorders as well, because it kind of goes together. But she just knows so much that I thought she would be a great person to interview me about the class because of her comprehensive understanding. So, Ashley, welcome.
Thank you. Thank you for having me, Keisha.
I'm so excited. Yeah. So you ready to go?
Yeah, let's go. So you have an upcoming course about OCD. So tell us, what is this course about? What do people need to know?
Okay, so it's called The Anatomy of OCD because I love creative names. I've learned I probably should change that, but I love creative names. So Diagnosing and Exposure and Response Prevention Treatment. I'm very passionate, and I think Ashley as well, about OCD and educating therapists because so many of us don't really know what it is when it comes in our office. We miss it. And so our clients suffer more. The common story is that most clients with OCD have been through so many therapists who have misdiagnosed them. Sometimes been diagnosed with like psychotic kind of stuff, like a psychosis or something like that, when it really was just an obsession about harm. So I think knowing what it is, whether you want to work with it or not, is really good and important for our profession. And I think understanding ERP, exposure and response prevention, is really good because, it can help with that and other things. It's just such I don't know, it's a staple of what I do.
So you mentioned a lot of people go a long time before they get the right treatment. So I think it's something like 14 to 17 years or something before they get the effective treatment, which most people consider ERP the gold standard. So I guess, like you said, even just recognizing that it's OCD is important, and recognizing that talk therapy probably can only help so much. So what is ERP?
So ERP, I consider it a counterintuitive approach, for treating mental health issues related to this. But exposure and response prevention is basically you expose yourself to the fear while abstaining from the compulsive behavior. In anxiety disorders, they call them safety behaviors, but basically anything you do repetitively to feel better. And so that sounds terrifying for our clients, and maybe terrifying for us as therapists to encourage our clients to do this, but it works beautifully. I mean, it's really crazy how it's almost like when we do compulsive behavior, and I say we because I have my own patterns, right? When we do compulsive behavior around an emotion. So if we have a feeling around an emotion and we do the compulsive behavior, it locks the feeling in. The more compulsive behavior we do, the more intense the feeling is. And when we abstain from the compulsive behavior, it can lessen the intensity, or if it doesn't lessen the intensity, because some people it doesn't, it will build tolerance for experiencing it. And so those things, it's just like a little trick of the human mind. When you understand that about compulsive behavior, you can be so much more intentional with your clients, and you build their self-esteem, which, I love that.
So, and I think too, being able to be trained in ERP, a lot of people tend to be oh my God, well, that's scary or that's cruel. But once you're trained in it, you kind of have more confidence in that, well, it's not it's not like you're making the client think or do anything that like is not already going on in their head. So, it's, and like you said, it can be challenging for the therapist as well. So having that training, so we're kind of like doing our own ERP sometimes, and like sitting with that discomfort with the client.
It's valid. And I think you bringing up that idea of cruelty, it is cruel in some ways. I think coming from where the background I come from, because I'm trained in trauma therapy, and trauma therapy, you attune so much to your client's nervous system and the subtleties of what goes on inside of them, that then to switch to ERP and like face your fear, it does feel very cruel. So what that would look like, but and look, when I'm in the trainings, like I got trained through the International OCD Foundation, and I'll take like consultation once a year. And when I say it's cruel, they laugh at me because they're like, it's not cruel. But I think because of my where I come from, I see the cruelty in it. I'm not denying it's cruel, right? But I think you're right that people are in this like fear all the time. So an example would be they're in their head about maybe they're like, oh my gosh, am I going to kill someone? Am I going to accidentally push someone down the stairs? Am I going to push my child in front of traffic? Right. And in ERP, you would be like, okay, lean into that feeling, right? Our tendency as therapists is to be like, oh, that's so unrealistic. Why would you not do that? Let's challenge that cognitively. You're a good mom, you're this, you're that. We want to reassure them. And that is not what helps people work through this stuff. And so by facing it, it does feel cruel, right? And by encouraging our clients to face it. But by doing that, I mean, by pushing in that way, they then learn that they can have these thoughts and feelings and they can tolerate them, right? And they don't have to do anything compulsively to reassure themselves, like not stand on the edge of things, or it just builds this sense of trust and kind of puts this idea inside of themselves that I don't want to say this too much, but that it's a thought in their head because you can't lead them there. But I think when they learn to tolerate it and they start to understand that it is a thought and I'm not doing the thing, and that's really powerful. So go ahead, sorry.
What about, can we use ERP for other, issues?
I use ERP for so much stuff. I have to be honest, like it really is a staple. So I'm trauma informed or a trauma therapist. So there's a piece of trauma therapy called stabilization where you're helping your client to deal with what's going on inside of them. And in that phase, I use ERP with phobias, panic disorder, anxiety disorders, social phobia, health, illness, anxiety, because it's very OCD like, and any sort of OCD that comes in my office, any sort of subtype, the taboo ones. Stabilization is about clients learning to manage what's going on inside of them. And so this can be just the foundation of what you do.
Yeah, and I like using ERP for like perfectionism too. That can be really helpful to like, okay, well, what happens if you make a mistake? Like what can you sit with that discomfort, or if things are not perfect. So yeah, that's interesting as well.
Well, and that leads down a rabbit hole, which I don't talk about a lot, that I'm very passionate about, overachieving. So
Mhm.
when I look at perfectionism, I look at overachieving. And me personally, I'm so goal driven that overachieving was like the way I lived my life for a long time. And perfectionism is a piece of that.
Mhm.
And in overachieving, probably the anxiety is, am I going to meet the goal? Right. So then people overwork and overdo things to be certain that they're going to meet the goal. So that's the compulsive pattern, and that gives them relief. And so we repeat times 1,000, and your life is full of that. So in overachieving, abstaining from your compulsions and facing that fear, I call it, I used to worry that the counseling police were going to come. Sort of praying like, oh no, they're going to come get me. I made a mistake on a protocol. I didn't do step 2 of a 4-part protocol, whatever. And it wasn't like I was harming anyone, but I was making mistakes. I wasn't doing it 100% every 100% of the time. So I think being able to face that fear and live with that uncertainty. Yeah, it can be used in so many things.
Mhm. So, and I know that you've been like treating OCD and treating these types of issues for a while with ERP. So why would somebody like come to your class specifically to be trained in diagnosing OCD and ERP?
It's interesting. Okay, yeah. So when I got trained, it was very expensive to be trained through BTTI. You had to fly to the place. I don't know what it is now. And I think it was like
Yeah.
maybe a
And
couple
there's a wait
thousand.
list.
Huh?
There's like
There's
a couple years wait list for BTTI.
Do you know that's what it was when the only reason I got in was because it was an accident, a glitch in the system. It scheduled me. I called in the first minute of it coming live and I got in and it was already full.
Wow.
Is that not crazy? And the system accidentally scheduled me for a course that was full. So they were like, next class, you will 100% be in. That's the only reason I got trained. So I do think it becomes like elitist in that sense. KDH Collective, I think we want to try to make education available for everyone at every level of learning. So whether you're a student into this topic, you're a new professional, or you've been doing this a long time, we try to make it affordable, and our pricing is according to that. Because you guys know when you're a PLPC or an LCSW or LMSW, you don't make as much money, and getting good quality education is hard. And so my hope is that by doing it this way, more people can be educated, whether or not they want to work with this issue or not, they'll at least know what it is. I mean, that statistic is crazy to me. 14 to 17 years. I'm researching it. I'm like, oh my gosh, that is disturbing in
Mhm.
this day and age, that is what it looks like if you have OCD.
Yeah, that's one of the main reasons that I'm like, I want to specialize in this because not a lot of people know about it. And like, I'm constantly getting clients that are like, yeah, I've been doing talk therapy for like 2 years or however many years. And like, yeah, it's been kind of helpful, but like, I'm still, having all these issues, all these things that I'm avoiding doing in my life, or like you said, like doing all these safety behaviors.
Well, and yeah. And look, even as you say that, my heart just like, oh, I hate when I hear that. And it's still so true. So when I got into this, I've been out of school 18 years. And probably when I got into, I don't even know how far into my profession, but it was at least 10 years ago, if not 12. Um, it was the same thing then. Do you know what I mean? The same story back then. And we're this many years later, we have social media, we have so many ways to like get information out there. I'm hoping, fingers crossed, that to be a part of this change, that people don't suffer that long anymore, especially when this is information that's been out there. I don't know why it's not so readily given when we're in school, right? Because we did study. I remember learning about OCD, but I didn't understand what it actually looked like.
Yeah. Or at least, I feel like we probably learned the common, like maybe they wash their hands too many times, or they like, don't step on cracks, or, whatever the stereotype is.
Yeah, but not the taboo, like, am I homicidal? Am
Yeah.
I a pedophile? Um, am I gay? I mean, there's a lot of different obsessions that people have that, are not openly discussed, that when you see can be scary.
Yeah.
Um,
And I love treating the taboo types of taboo, like things that are hard for people to talk about because they're like, well, if I tell somebody, like, am I going to be arrested, or my kid's going to be taken away? Like, is my pet going to be taken away? But like, it's so important to have somebody who is willing to talk about that.
Agreed. Who dives in? Again, ERP teaches you to face the thing that's uncomfortable, right? And so once you learn that and you learn your client didn't break, you actually helped them by naming it and really going in. I don't know. That is a powerful, powerful thing. And it changes the way we work in all areas. I'm not scared of any of that stuff anymore. Do you know what I mean? Like, even if somebody wants to die, I'm like, okay, what are your thoughts? Like, I'm not afraid of any of it. Like, how deep down the rabbit hole do we go? I don't stop anywhere. Let's just go all the way down. Let's see what it is.
Yeah.
Um, the other piece of this that I think is really important, because you kind of touched on it, is that multicultural piece. And so it wasn't addressed much in my course, or I don't remember it. So let me say that. in all fairness. I don't remember it. It's something I'm really passionate about in KDH Collective, that I feel like we have to look at all racial identity groups when we're looking at treating people and helping them, and looking at differences are not differences, right? And so with this issue, I think one thing to really keep in mind is in the Black population, or the BIPOC, what is it? BIPOC?
Mhm.
Black, Indigenous, I
People
don't know.
of color, yeah.
People of color, yes. I mix up what words mean. I say things backwards all the time. Okay, so in that population, I think, or in those populations, often those individuals have more barriers to overcome in seeking treatment because of the taboo nature of OCD, right? It's scary for anyone to talk about the thoughts that they're having, but in these populations, it's even scarier because of things that have happened in our history. So I was doing a little bit of research on it. There's something called the lead paint study. Did you hear about this?
Um, nope. I don't think.
Okay. So this went on. I'm trying to remember who it was by. Anyway, it was a study that was done, I think, in the 90s. Okay,
Mhm.
again, my lifetime, I was almost an adult then. It's crazy to me.
Yeah.
They tried to find a quicker way to take lead paint off the walls in like impoverished apartment complexes. So they took it off in this cheaper way, and then they let families move in. Didn't tell them the risk that there's possibly lead paint, and studied if it affected them or not. I mean, this was in the 90s, y'all. This is crazy to me.
Where was that? Do you remember?
I want to say Baltimore. I don't know. It's in the presentation. I'll go into detail more. But
Yeah.
it's one of the things that the International OCD Foundation kind of quotes in terms of like when they're trying to research OCD in that population or in those populations, it's really hard for people to even seek help because they don't trust doctors or professionals because of the history of mistreatment.
I'm sure it's hard to get people to participate in research as well about OCD and related disorders. Yeah.
Correct. Correct. And so, I mean, all of our classes, we try to provide education on that, and we're trying to be even more intentional when it comes to that, um, to racial differences and and how to address it effectively and be informed.
Yeah,
You
I
know,
think that's so important. And like if, if we're not like getting that information from classes, they're missing like a huge chunk of what we need to know as professionals.
well, yeah, and I do want to say this last piece, like even though there's not a lot of research, in terms of the human brain, all our brains are similar. It's our skin color that's different. But the neurology of us as humans, as a species, is the same. And OCD is a biological diagnosis. If you did not know, people with OCD have more gray matter in their brain. Um, and there's some interesting stuff, pandas. There's all these diagnoses that kids get and that cause OCD. It's really fascinating. But so we are similar inside, even though we might be different on the outside. And so treating it, we have to look at cultural differences when we're helping people, but I think some of the basic components can stay the same across all races. So any other questions for me?
Um, I don't know. Was there anything that like I didn't ask about that you think would be important for people who are interested in the class to know?
Other big thing that I'm hardcore into is neurodivergence and how that shows up in the therapy room. So neurodiversity is neurological differences across the whole human race, right? And neurodivergence is like the when we diverge from the norm. So in that realm is OCD, which is fascinating, right? Because it's biological. ADHD, which I am, so I have a special interest in that. Inattentive and hyperactive subtypes, right? All ADHD, autism, and there's a bunch of other things like trauma, anything that changes the brain. There's so many things that go into this, right? But I think I like to include this when I'm looking at ERP and how I treat individuals, because when it is a neurodivergence related difference, I think it's important that our clients know about these differences and we tweak it. because sometimes compulsions can be stemming, which is common in autism. And so when it's that we look at it just slightly different, we just tweak it a little bit. The neurodiversity affirming therapy movement is like, it's mixed with a lot of stuff, right? Sometimes it becomes so watered down. I'm like, are we even helping our clients? People come to us because they're struggling. And if we're just saying it's neurological, and I guess, oh, well, it's neurological, you have OCD, so I guess you're just going to suffer with it. I mean, we're not really helping. And so I'm super practical. I include this information to be practical and helpful. So if people want this approach, right, if our clients want to participate, you cannot make anyone do ERP, even a child. You cannot. It has to willingly be engaged upon or in. And that's
Or,
kind of, go ahead.
well, I was going to say, or you probably won't have success, right? If you're trying to get them to do all these things that are scary and they're like, I'm not motivated to do this, they're going to be like white knuckling through it, like gritting their teeth, which is not going to give them that learning that we want them to get.
What is the learning? I love that. Yes, that's such a good, huh?
Inhibitory learning.
Love that. Yes, that's some new research. I don't know, in the last couple of years that came out that they think that's why it works, right? It's new learning that inhibits the old learning. And I don't know, there's something so beautiful about that learning. For me, like there's so much in that. I could talk probably for an hour just about that idea. Because I think we as therapists, that's a big part of what we do. We're creating inhibitory learning no matter what we're treating.
Yeah, good point.
It's just almost like a staple of good therapy work.
Mhm. Yeah, I never thought of it like that, but yeah, that does make sense.
It's beautiful. So yeah, if y'all want to learn more, please check it out. It's for therapists. I'm credentialed or KDH Collective. We got approval through NASW for this course and NBCC. So you get CEUs through both of them. It's 6 CEUs. It's on a Saturday. Yeah, so everyone can attend. And you'll see it's a lot to cover in the time, but it is interactive. It's a live webinar. You can talk, you can ask questions, and I'm always available after for consultation. I think that learning, like good learning, a good training, you take and then you consult. Because consulting is like when you start to like do this real time, you get so many more questions. Like, am I doing this right? And I know me and you will go back and forth. Is this a good exposure? Wait, what about this one? Is this a good exposure? And I think that's kind of fun, like figuring out the right one.
Yeah, and there's you can get like all the basics in the training, but like you have to keep learning. Like even both of us are still learning and like we've been familiar with this or working with this for a long time. So yeah, it's vital.
Agreed. What are your last thoughts on all this, Ashley? Because I think we both share our love of learning and continuing to learn about this stuff and do better. I mean, is it really the right word to do better with it? I don't know. What are
I
your
mean,
thoughts on that? Yeah.
so for me, it's like there's so many different presentations, I guess, of OCD or of like related disorders. So it's being creative and it's like, I don't know, having new ways of looking at things or, and obviously like there's always research going on, like maybe there's going to be new ways of doing things. So yeah, I mean, I just love learning. I've always been like a reader, even as a little kid, just learning and like experiencing new things. So yeah, to me, it's like, how could you do this job and not continue to learn? Yeah.
Well, and Ashley, that's why I was so glad when you started working with this. So Ashley loves OCD like I do, and she loves learning. It's like one of the things that I think makes for a really good therapist is our ability to be open to continue to learn. Um, yeah. I'm still like last year I did a deep dive into deep brain reorienting and like, man, I took so many trainings. I did a consultation that was a solid day once a month, like in the middle of my week. I was like, what was I thinking? What was I thinking? I couldn't see clients. That was a solid day of training. But I think, and then on the side of that, because it was such a complicated thing for me to understand, I would study. We call it the DBR beatdown. So we would like try to understand what was going on in the brain. Um, and I think that kind of learning, like it just continues to shape us as therapists, you know? We evolve, we understand more. And then one of the things that I think is like so important is that we through that process, when you start trusting yourself, you develop your own insights and your own kind of take on what's important and how that should be facilitated. And that's something that when I'm working or in a consultation group or anything, if someone's like, well, the protocol calls for XYZ, I'm like, well, yeah. And they're trying to figure out how to work with their own clientele with it. I'm like, yeah, okay. So what do you know about your clientele that this protocol doesn't know about that you need to tweak to make work for your population? And some therapists like really struggle with that idea, like, can I trust myself enough to do it my way? I'm like, oh, yeah. You know, when you learn enough, you just start having an opinion.
And I think that's where like having that knowledge of like the neurodivergence piece is important, because if they have some of these like other neurodivergences, like you have to be able to know the client in order to know like, okay, well, this is not working. Like the protocol's not working. Like, how else can I do this?
That's valid. I love that. So it's a little more, it's more tailored to their individual needs, a little more collaborative. Because old school, it's like, this is the protocol and this is what you do. And what we're talking about, it's a little more collaborative and we allow it to grow. Like it's an organism that changes with time and with clients. I love that. It's organic. Yeah. Yeah.
Perfect. Yeah, I'm excited about the class, and yeah, I hope to see everybody there.
Thank you so much.